Calgary. She's a geriatric psychiatrist. I know her well. She's a great contributor to the work of our national bodies, the CAGP and CCSMH. And she's going to be giving us our didactic today. So great to have you, Julia, and I'll pass over to you.
Right. Thanks, David, and thanks for having me. I will go through the necessary sort of things here. I don't have no real conflicts of interest to declare that are relevant to this topic, but I do have grant funding from CIHR, the CCNA, and the Alzheimer's Society of Canada. Won't be talking about any work supported by those grants. I understand this program has only received support from the Public Health Agency of Canada, and as I said, no conflicts of interest on my part. The program is explicitly evidence-based. I think I'm supposed to say this, but I'm going to say that some of this is anecdotal. I did my best to make this evidence-based, but the thing is, there's not a lot of evidence on psychosis in older adults if we're talking about anything other than dementia. So I've taken some liberties. I'll try to point out where I'm talking about some of my experience from practice, but I did my best to make this a really, try to make this really practical based on, what I tend to see a lot, and also what I tend to have a lot of difficulty finding answers on, or I remember, when I first started looking things up and tried to address some of those gaps. So it's evidence-based mostly. All right, so I do plan to provide a very brief overview of the epidemiology of late life psychosis. That's actually highly relevant to the differential diagnosis, which I'll also talk about, and we'll talk about some typical presentations, again, like what are common clinical symptoms with each of these different etiologies. And then I'll review just a very basic approach to treatment. It's not possible because treatment is very different for each of the different conditions, and all the different things that can cause psychosis. I don't think it's really realistic to talk about treatment individually for each, but I'll tell you, like what a geriatric psychiatrist approaches to treatment and some kind of special, I call them special considerations. So you'll see. All right. So in terms of epidemiology, the lifetime risk for psychotic symptoms in older adults is quite high, so almost a quarter. That's largely driven by dementia. About 60% of older patients with new psychosis have a secondary psychosis. And so what I mean by that is psychotic symptoms in older adults are not usually a primary psychiatric disorder. A primary psychiatric disorder refers to things where psychotic symptoms are a core feature of the disorder. So for example, schizophrenia, delusional disorder, mood disorders that can present with psychosis, those would be considered primary causes of psychosis. A secondary psychotic disorder is where those symptoms are not kind of the main part. They're secondary to whatever the actual primary cause is. So among secondary causes, dementia is the most common for psychotic symptoms in older adults by a long shot. So a way of remembering the causes is the 6 Ds of late life psychosis: delirium, disease, which refers to basically like medical conditions, drugs, dementia, depression, and delusional disorder. And I just wanted to highlight a couple of things in terms of the numbers here. So one, schizophrenia is a very rare diagnosis in older adults, as it is in the general population, about 1%. And so in terms of proportion of all causes of psychosis, this is the least likely. Depression is more common than you think. Psychotic symptoms, particularly in older adults, are more common with depression than in younger people. And then, of course, as I said, dementia is the most common reason. So although I said schizophrenia is not common, part of the talk was supposed to be on schizophrenia, so I'll talk about it. But I think for most of you, you're not going to see a lot of this in your practice. Depends a lot on what your practice looks like. I should have mentioned I work as an outpatient psychiatrist, and so I would say like and where you work is going to influence what type of psychosis you see. So for an inpatient, of course, the most likely cause of psychosis is probably going to be delirium. In outpatients, I see schizophrenia quite rarely, and there's a few reasons for that. One is that there's a survival bias. So there is a very significant mortality gap compared to the general population in schizophrenia. People die about 15 to 20 years younger than the general population. This mortality gap is not improving despite improvements in treatment for mental health and physical comorbidities. And so that's part of the reason we don't see this that often. And then the other reason has to do with the clinical course of schizophrenia in older adults, which it does tend to be more stable for a variety of reasons and less likely to present, for clinical or require as much clinical attention. So schizophrenia, I'll talk about the different types, but when we talk about schizophrenia in general in this presentation, I'm referring to the most common type, which is, has its onset in early adulthood, so in teens or early 20s for men and a little bit later for women. The prevalence is lower among older adults than the general population in younger people, which would be about 1%. And contrary to, I think, some assumptions, schizophrenia or the direct effects of mental health like suicide that's not the reason for premature mortality. It's largely due to cardiovascular disease. Most common reason that people die prematurely. People do have an elevated risk of dementia. It's complicated though, I'll talk about that. And then there are two other forms of schizophrenia. So when we say late and onset schizophrenia, that's in people who are developing the disease between the ages of 40 and 60. I would call that rare, like you might see it occasionally. And then very late onset schizophrenia. So in people who are older than 60 years old, and that's extremely rare. It's a diagnosis of exclusion. So you've ruled out everything else. Maybe this is very late onset schizophrenia. I can tell you that in my practice, I have never seen what I actually thought was a very late onset schizophrenia. I have seen late onset, so extremely unusual. And there's some controversy about whether this is actually schizophrenia or a different problem, because people tend to have quite a different presentation. All right, so this is some clinical features of early onset, late onset, and very late onset schizophrenia. And again, just wanted to point out a few of the highlights here. So in types of schizophrenia arising in later age, there's a female preponderance. Negative symptoms are less likely in very late onset schizophrenia. In terms of positive symptoms, that means like hallucinations, psychotic symptoms are more likely. And then people have more cognitive impairment in very late onset schizophrenia. This is part of the reason why there's a question about whether this is actually some type of neurodegenerative disease as opposed to the early onset form. Brain structural abnormalities are more common, and there's a weak association with family history of psychotic illness and very late onset, whereas there is an association with family history in those other forms of schizophrenia. All right, so people who have I'm generally speaking to the early onset form of schizophrenia, but as they age, they do have accelerated physical aging. I mentioned that the early or premature mortality, a major contributor, and this has been shown, time and time again, to premature mortality is inadequate medical care or poor quality medical care, including under treatment or inadequate treatment of potentially reversible or treatable cardiovascular risk factors. Like people are, for example, much likely to receive a beta blocker, much likely to receive procedures after an MI, or preventative treatment for cardiovascular risk, much likely to receive routine cancer screening like pap smears. I could go on and on, but we can talk about that if you guys want. However, in general, we don't totally understand the mechanisms that are underlying this accelerated physical aging and mortality. So they do have, generally speaking, normal cognitive aging. All people who have schizophrenia have some mild cognitive impairment that starts from illness onset or even in premorbid stages of illness, but that is stable and persistent throughout their life, meaning that they have some cognitive impairment at all ages. But what can happen with aging is that people have some additive effect. And so people with existing cognitive deficits with the cumulative effect of some cognitive aging may look like they have worsening cognition. And in my experience, some of those people do have worsening cognition and dementia. And some of those people, it really is stable over time, and it's aging on top of existing difficulty. So in general, with aging, people who are affected by schizophrenia have actually better psychosocial functioning and fewer psychotic symptoms and relapses. There's a lot of, people are different. Schizophrenia is generally not a homogeneous disorder. So this is, in general, there's going to be exceptions, but by and large, there is more stability in this illness as people age. And the reasons are complicated. Some of them are related to changes in the brain and aging, which might be, in a sense, protective against relapse, but some of them are related to psychosocial factors as well. So for example, supportive relationships, better self-management, things like that. And it's been called the aging paradox. So this, better social functioning, kind of less illness severity combined with accelerated or worsened physical aging is referred to as the aging paradox in schizophrenia. All right, so in terms of the clinical presentation, again, it's important to know how different psychotic syndromes present because it sheds light onto the etiology. And so schizophrenia is quite unique among older adults in how it presents. So auditory hallucinations are quite common. Bizarre or complex delusions, often persecutory delusions. So people will often have it's like strange things about, some organization controlling events and their thoughts, etc. Like quite unusual. I can give other examples of bizarre or complex if people are wondering what that means. But that is a difference from, for example, how psychosis due to dementia would present, which tends to be much simpler, like I saw a man in my house, or, I heard people downstairs and they came in and stole something, not a complicated system of delusional beliefs. People also can have first-rank symptoms, which again does not happen typically in other types of psychosis. So that's things like thought broadcasting or control, believing people can hear your thoughts or someone is controlling what you think. And I find often in later life that people who have schizophrenia have some persistent psychotic symptoms at baseline. So even with treatment and a fairly high, level of functioning, there are many people who still have some ongoing psychotic symptoms, but is well treated or controlled enough that it doesn't interfere, a lot with their day-to-day functioning. And if they have a relapse, it looks like a worsening of that baseline, not necessarily new symptoms. All right, I want to talk about delusional disorder. If you work in the community with older adults, you're going to see a lot of this, I think. And it is challenging. So the onset is in mid to late life. Average age of onset is around 50, and the prevalence is quite low, about 0.3 to 0.05 or 0.03 to 0.05 in most sources. And there's no gender predominance, so men and women equally. It presents very similarly in most people. Like I find if you've seen it, it looks the same. The nature of the delusion is different, but it kind of looks the same in everybody. And if you've seen it once, you know it. And so people have a core fixed delusion. They might have many other beliefs or delusions, ideas of reference, but it always relates to this central delusional belief. An idea of reference is when you attribute meaning of something like as if it's relevant to you. So for example, I have a patient who the neighbors don't talk to him when he's out on his walk. He, walks past them and they don't make eye contact with him, which I think is just kind of how a lot of people are these days. But he attributes that as directly related to him in that they're aware of this thing he's been accused of. And so they don't want to talk to him, et cetera. It has all this meaning for him, which is like objectively, this is just a totally benign thing. Anyways, so they will have, sometimes it seems like they have a lot of delusions, but if you probe, it always comes back to this kind of main thing, sometimes which is in the distant past, but there's like a core or central belief, which is what we mean by that. So they sometimes have social dysfunction, meaning there can be a lot of conflicts in relationships, especially with loved ones. It will be plainly obvious to most people that this cannot be true. And so that creates a lot of conflict, but typically their functioning is normal otherwise. So they rarely would have cognitive, occupational, or day-to-day functioning. And for this reason, people rarely, end up in hospital or presenting to the emergency department, and sometimes don't present for clinical attention as well. This is why this prevalence, might be underestimated because we may not be seeing these people. They tend to get by, and live with their delusion in a fairly chronic way. They have no insight, and that is, again, a hallmark of this problem. So depression, I mentioned it because it can be really easily missed. I actually see it missed a lot. And that's because it looks different than other types of psychosis. But again, when you've seen it among older adults, it looks similar usually. The type of presentation you see with depression and psychosis in older adults is more similar than it is different, but it's different than other types of psychosis, if that makes sense. So this psychosis is usually mood congruent. So people will have delusions with themes of guilt, feeling like they deserve some kind of punishment for personal failures, nihilism, like poverty, things like the world is ending or something like very bad is going to happen, this sense of that. And psychosis is more common compared to younger people due to depression is more common. You will see it more often in older adults than younger people, but it can be subtle. So you're not really looking for overt. People are not typically going to come to your office and be like, oh, I have this, wild belief. And this is why I see it missed. It often looks like just very kind of strange worry or preoccupation. Things that I've seen numerous times is unusual beliefs about health to the point of obsessiveness. So for example, a patient who felt like he was losing his eyesight, there was no evidence that he was losing his eyesight, and he was just completely, totally preoccupied with it. Concerns about the bills being paid or the heat going off and things like that when there's no justification or rationale for it. So these are some examples of how it can present subtly. So if you have a patient who has some evidence of depression, or there's some suspicion for that, and has what strikes you as unusual or slightly irrational worry, I would be very suspicious about psychosis. It can happen in people, it's not always in people who have this history of severe depression. I've seen numerous times people with a first episode of depression in older age, and they have a psychotic depression. Often there's some history earlier in life of maybe a depressive episode, but rarely a significant psychiatric history. And There is often, before psychosis develops into depression, a period where there are depressive symptoms. Again, you have to do your digging on the history, but typically people have a period with depressive symptoms without psychosis, that often goes on a long time, and then the psychosis develops. I'm not going to talk a whole lot about dementia because I'm guessing people are probably more familiar with psychosis and dementia maybe than some of the other causes, and could be a presentation in and of itself, but quite common, especially in people with Alzheimer's dementia, a little bit less common in vascular dementia. Of course, very common in Lewy body disease. About 80% of people will have visual hallucinations. Keep in mind, in Lewy body disease, psychosis can present with delusions. It's not always visual hallucinations. And keep in mind also that not everyone with Lewy body disease presents with psychosis. A majority do, but you can have Lewy body disease and not necessarily have hallucinations. Visual hallucinations are more common compared to, for example, auditory hallucinations in all dementia. And I mentioned previously, basically, what I described in terms of schizophrenia is different than how, psychosis due to dementia presents. In Alzheimer's disease in particular, hallucinations are a bit more common in moderate to later disease stages, but delusions are common in earlier stages, especially like persecutory delusions, delusions of theft or infidelity. I see that one a lot. And I wanted to mention that not all psychosis is psychosis. Again, history is really important. So these are some examples from my practice. So it may seem sometimes like someone is having a visual hallucination, but it's not always a visual hallucination. So for example, when people say something like, I looked out my window and I saw a man, sometimes that's a visual hallucination. I find a lot of time that can be a misperception, or there's a visual stimuli like a tree, and people have a bit of visual impairment and they're misperceiving something that's actually there, or an illusion, we call that. This one is common, of course, if you have any patients with dementia, like something's missing and, they assume or infer that someone stole it. They've misplaced something, right? So therefore someone must have stolen it. Like, I often see that called a psychotic symptom, but I'm not sure that it is. Sometimes it is because there's this other kind of, paranoid ideation or other persecutory beliefs. But sometimes this is what I call it filling in the blanks. If you're like, well, I'm sure I left my jacket there and it's not there, sometimes it's more cognitive than it is psychotic. And then, confusing TV or dreams with reality is common too, and is not psychosis. This is all important because it really guides how we treat this and whether we treat it. All right. I also wanted to mention these. In particular, I wanted to talk about auditory hallucinations. This is one of the ones I never heard anything about in my training. I can't find anything about it in the literature, really. And I see it quite often. So I wanted to take this opportunity to talk a little bit about it if you're in the same boat and have come across this. So this is called release phenomenon. And I'm sure people are familiar with Charles Bonnet. Like we hear about that. We hear about that in clinical training, but it's basically visual hallucinations, usually, because people are visually impaired. And again, it's like the mind is filling in the blanks. The visual system is not getting the typical stimulus, and people have, hallucinations. Classically, these are not distressing. They are like simple, so they're not complicated. Like I saw a whole family and the dog and the cat. It's like I saw one thing, or I saw a spot. And the treatment is not antipsychotics, but it's to optimize vision, provide reassurance. Now, I think people know about that, but I don't know if people know that there is an auditory form of this. And sometimes it's called musical hallucinations, music or noises like buzzing or classically how it will present, but I have seen it present with more complex symptoms like voices or other types of noises, and it sometimes can be quite distressing. A patient of mine once called it musical ear syndrome. And she said to me, oh yeah, I was explaining what I thought it was. And she said, oh yeah, like my mother had this musical ear syndrome, which I never heard of. And sure enough, I looked it up and there's a little bit of information on that. So there you go. Anyway, again, the treatment is usually not antipsychotics, but auditory distraction. So for example, using like white noise or music, other types of distraction, optimizing hearing, of course, treating any comorbidities, and then, you know, again, providing reassurance and education to the person and family. All right, so just approach to diagnosis. So the two most important questions you want to ask yourself are what kind of symptoms do they have? It is going to tell you a lot about the most likely cause, because as I explained, you know, the typical causes, you know, tend to present in a very, you know, specific way. Once you become familiar with that, that will be very helpful in terms of arriving at an accurate diagnosis. And what's the timeline? Also very important. So, you know, particularly in differentiating from primary or secondary causes, you know, most people with a primary cause, like a psychiatric disorder, are going to have some early life history. So, you know, 90% of the time, I would say, you're going to see some evidence in early life of a psychiatric problem. Any new problem should, you know, be very suspicious for a secondary cause until proven otherwise. So you want to do a good workup, and you want to think about, you know, all the secondary causes I talked about. Also, don't forget about drugs. So both prescribed drugs, and lately I'm seeing also cannabis as a, you know, potential cause or contributor to psychosis. All right. And then there's no guidelines on specific workup that you need to do. So use your judgment and, you know, some of the typical things we would think about in an older adult, but no right or wrong way to do the workup. So treatment, I mentioned, like, it's really hard to talk about treatment because everything is treated differently. So I'm going to tell you like what my approach is, and then some special considerations that I think is hard to find in, you know, available resources. And so when you're deciding whether to treat, you want to think about, does the degree of distress or dysfunction justify treatment with antipsychotic or changes in their treatment? And I mention this because I find people, especially like family, get really freaked out about psychosis. You know, people will come to you and it's actually not that much of a problem, you know. So for example, like in a delusional disorder, sometimes people have been living with it for like 10, I just had a patient 20 years, he's had this problem. But it really bothers family members. And I think like the reaction, if I was to sum it up, is to be like, well, this person got a hallucination. Like, obviously, you know, they're crazy, you have to treat them. It's not language I would use, but that's what I see as the attitude from family. And providing education and reassurance can be really important, you know, when it's a situation where you don't believe treatment is necessary, indicated, or that the problem is likely to respond to treatment. So don't forget that not all psychosis requires treatment. And a very important part of the conversation is, you know, thinking about whether treatment is justified and reassuring family that, you know, it's not always needed. You also have to think about, you know, the person's preference, whether they want treatment and their capacity, because that will guide treatment decisions about whether or not you treat. When you're deciding what to use, you generally treat based on the underlying etiology and the comorbidities. The general principle is to go slow and to start low, but do use an adequate dose, particularly when you're treating psychosis with antipsychotics. Antipsychotic effective medications is dose dependent. And if you undertreat people, you're effectively, you know, not treating psychosis. Again, depends on the patient's comorbidities and the cause. Just for time, I think I'm going to skip this. I was going to talk a little bit about antipsychotic potency. I mean, the point is that for antipsychotic effects of medications, you have to get to a certain dose. So a couple just like special considerations. This is not an exhaustive discussion about treatment, of course, but in terms of depression with psychosis, ECT, if it's available or possible, is probably the gold standard. And if not, you need to use an antidepressant and an antipsychotic. You have to use a combination. There's really only evidence for olanzapine and sertraline, but in practice, we use any combination. The important thing is it has to be a combination. Generally won't respond to an antidepressant or an antipsychotic alone. Delusional disorder, all the resources you'll see out there will say that, you should use an antipsychotic. It does not respond well. However, I actually have never seen a great response in delusional disorder to antipsychotics. We sometimes use them to decrease the intensity and preoccupation with the delusion. They will work in that way, but they will not typically make the delusion go away. That's important in terms of your own treatment expectations, and again, providing the education so family and the person understand what to expect. But they often have comorbid depression or anxiety? This can be, like I said, cause a lot of social dysfunction. And so do watch for that and treat those, as you normally would. Okay. The only thing I have to say about schizophrenia is that, again, you usually have to, you want antipsychotic effects, especially in schizophrenia, because, psychotic symptoms can be very upsetting. And so doses are going to typically be a little bit higher for that antipsychotic effect. By higher, I mean, they're not high from a psychiatrist perspective, but I think often people feel uncomfortable with these types of doses because they're not typically what we would use, for example, in an older adult with dementia. But most patients with schizophrenia are going to be on higher doses of medication or require high doses of medication. And then the only other thing I have to say based on experience is do not switch medications if patients are stable just for a theoretical or seems like a good idea. So I often see people saying, well, this patient is on this old medication that we've, never heard of, we never use anymore. Shouldn't we switch them to an atypical? Generally speaking, no, unless they have, side effects or some other reason that you would want to switch them, because that will often destabilize a patient, and it can be very hard to get things back on track. Same thing, for patients who have really severe tardive dyskinesia, stopping the medication if the tardive dyskinesia has been longstanding does not always resolve the problem. So you have to think carefully about, how much of an issue is this causing, and is a change actually likely to help. But do attempt to reduce polypharmacy, and do also review anticholinergic medications. I find that often people who have schizophrenia who age are on a lot of anticholinergic or other medications that can be reduced, not always stopped. All right, I'm over time, so I went through that last part really quickly, but I'm happy to take any questions.
Thanks so much, Julia. That was a great talk. If you could just end sharing your, well, it's good that you put up your email there. If anyone wants to contact you, I presume it's okay if they have
Yeah, sure.
your questions, etc. A couple of questions in the chat, so maybe we'll start with those. The first is from Lara, who asks, the cardiovascular risk that you mentioned earlier, how much of that is due to medications directly? Antipsychotics, I guess, in particular.
I don't think we can answer that question. I would say not all of it. But, it's complicated because, lifestyle factors come into play. So, smoking, very, very high rates of smoking, contribute to cardiovascular risk, sedentary lifestyle, which is quite common, disadvantaged socioeconomic status, and all the things, all the ways that can increase cardiovascular risk. So I would say, I don't think we could quantify, or I have never seen that, in terms of medication, quantifiable for medication related. It's probably more complicated, but it's not all medication related. And just a note, like there is evidence showing that if you treat people who have cardiovascular risk, you can reduce mortality. So I think, there's often this assumption in schizophrenia that it's like too complicated, or all like, people just smoke. So what are you going to do? Like, everyone smokes. I think there's a lot of stigma in the treatment of schizophrenia still, unfortunately. And so I just wanted to mention there is evidence that if you treat cardiovascular risk, you can reduce mortality. The problem is not so much the high rates of cardiovascular risk. Of course, that's part of it. The bigger problem is that it is not treated.
Okay. Really interesting question from Hilary Thome. So they have a client who's got, quotes, paranoid schizoid personality disorder. So personality disorder with, those features, paranoid or schizoid. And could you make some comments about that diagnosis and how it might differentiate from, say, true psychosis?
Yeah, that's tricky. I didn't get into it. It just gets like so complex. And so I tried to kind of stick to the bread and butter type of things if you work with older adults. But I would say, when the diagnosis is a personality disorder, I would say, in my experience, the dysfunction associated with the problem is a little bit less. So often, again, they have a lot of social dysfunction, but they rarely have been in hospital, for example, for long periods of time. Whereas, that's typically quite different. Most of my patients that have schizophrenia have a history often of, long hospitalizations, in and out of hospital early in life, many psychiatrists over the years. And that would be one of the big differences I see. But of course, the timeline is important too. So, personality disorder is present from a very early point in life, and it can be important to have collateral history. That's very useful when you're talking about personality disorders, because, family or loved one, it could be tricky when you're talking about those, like schizoid, for example. You might not have many people around them, but, family will tell you exactly, if that has been the case for many, 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 many years. And that's going to be a clue, I would say. Those are probably the big things I would look for, is the history and how long it's been there, some of the collateral information, and, the degree of dysfunction, and particularly like hospitalizations or problems associated with that paranoia. David, do you want to chime in? Or are there other geriatric psychiatrists here? Because that's a tricky...
Yeah, no, I think we'll
tricky one,
because that is a tricky one. But lifelong pattern obviously is a critical part of that. Just going to take a few other questions before we move to the cases, because we're doing 2 cases today. So I'm not necessarily going to deal with all of the questions in the chat, but maybe we could deal with some of those later in terms of actually getting back to you with answers. Just going to take one question I think is very interesting, and that is quotes from Brooke. When working with a patient who is fixated on a specific delusion, is it at all recommended or effective to gently ask questions to help the person critically consider the situation?
Oh, yes. Yeah. Yeah, I feel very confident answering this, because I don't know what's happened now, but I have so many patients with delusional disorder at the moment. So it can be helpful to help them critically challenge the delusion, but I would say it depends a lot what you're doing and how you're doing it. And I would not spend a lot of time or energy on it. Like, the line that I can tell you I find most helpful with people I see who have delusional disorders is, it just resonates with people. I'll say, listen, I believe you're having this experience, but, from my perspective, this experience is created by the brain. It feels very real to you. It's the difference between the outside world and, the brain creating this experience. And I give people examples of all the ways the brain controls the entire body, and then I say, listen, at the end of the day, we agree to disagree. It really doesn't matter what we think is causing this. What we both care about is the amount of distress or stress you're under. And that's what I'm worried about, you know, and that tends to, I find, just resonate with people a bit more than getting in. What you do not want to do is get in a circular kind of conversation about like, or provide evidence to the contrary. And you don't want family doing this either. You know, family would be like, should we put a camera in? I'm like, don't waste your time. Been there, done that. Doesn't work, doesn't do anything. And you don't want to try to use like reason with people. Like, well, if only like I kind of walk you through this logical process, like you'll realize it never, ever works. This is some of the education I provide to family too. Like, do not do this. It just ends in frustration for everyone. As I said, like I have that line about, you know, where we can agree is how you're feeling and how this is affecting you. And that's kind of what I tend to focus on. And that's useful. And then it can be helpful to create doubt around the delusional beliefs, but the goal isn't that they resolve, but maybe that people sort of sometimes question them. So I only do this in patients who are a bit more insightful or open-minded. By insightful, I mean, no one ever with a delusional disorder actually told me they believed me that they have delusional, but I have some patients who will say, for example, like, well, I know you think this is a delusion. So like, I'm open to hearing about, you know, what I might do to kind of make it bother me a little bit less. So I would say they're insightful in that they realize, you know, and they accept that maybe, but it's superficial. So in those people, it can be helpful to just kind of, you know, challenge and it's not with the goal of it resolving, but for example, like so the patient I mentioned who thinks his neighbors aren't looking at him because he has a very complicated delusion I won't get into, but the neighbor's not looking at him all relates to the delusion. And so one thing we do with him is say, well, are the other reasons the neighbors might be not looking at you? And that, you know, it may not be every time, but can you think of some other causes for that happening? And so in that sense, it can be useful to challenge this in a way. But again, the goal, you don't want to fall into like the logical reasoning trap. It never works.
Thanks a lot, Julia. The other questions are great as well. Thanks everyone for putting those questions in the chat. We'll take note of those and if possible, we'll get back to you. Let's move on. We have 2 cases today, so we'll have